Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. The Spark theme for October is Children's Healthcare in the Community, and I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made in shaping and strengthening this community, our province, and the country. We're delighted to speak with Dr. Ripudaman Minhas, to bring you Creating Community Partnerships for Greater Equity and Access to Children's Health. Before we begin, we invite you to answer a few quick poll questions for us. Please note that you'll have to answer all three questions to submit your response. I'll give you a couple of moments to answer the question. And while you are, I will introduce our speaker for today. Dr. Ripudaman Minhas is a developmental pediatrician at St. Michael's Hospital, Unity Health, Toronto, and is an associate professor of pediatrics. He's the director of research for the Department of Pediatrics at St. Michael's Hospital and the founder of Our Kids Health Network, a community-led, social media-based child health promotion program that delivers evidence-based health information online for families with diverse cultural, linguistic identities. During the presentation, we welcome you to converse in the chat box and type your questions in the question and answer box, which we will pose to our speaker at the end of the webinar. Thank you so much for participating in the questionnaire, in the poll, and it is now my pleasure to pass the mic to Dr. Minhas.
Hi, everyone. I'm just going to share my screen and we can get started. There we go. So I trust that that is showing up on your screen. If it's not, let me know. Okay, wonderful. So thanks so much, Paula, and to the whole Spark team. As a developmental pediatrician, I think of my clinical role as someone who helps families understand their children's brains better. So I help give them information about their strengths, their needs, and profiles so they can make decisions that they need to optimize their children's developmental potential. I think of the developmental assessment process as a journey in which families, patients, and I embark together to explore and share knowledge and observations. They're the experts in their child, and I'm the medical or developmental or content expert. It's a partnership. Likewise, in my area of passion and advocacy and research work, I partner with families to explore what health systems work or don't work for their family's reality. Sometimes the biggest lessons I find come when things don't seem to be working out as planned. And I changed the term from the original title of creating to cultivating, because I think it's really about taking what's already out there in our health systems and enriching them, rebuilding them, and layering on new modes of learning for us as well. And it's an ongoing process. And I think it's about deconstructing some of our systems into core ideas and really rethinking some of those. So again, my name is Ripudaman Minhas. I'm a developmental pediatrician at St. Michael's Hospital, Unity Health, Toronto. And over the next half hour or so, I'm going to share some of my team's work And it is a team that's done this. I'm just the person that gets to come and share some of these ideas with you. In our work in creating and cultivating community partnerships in the hope of greater equity and improved access in children's health. I have no conflicts of interest to declare in reference of today's conversation. And before we delve into our topic, I'd like to again acknowledge the land from which I'm working today. I think it's really powerful and important to begin important work with acknowledgement. I think it helps to serve both in grounding us in our conversation in the current moment, and also reminding us of the importance of context and humanity and our responsibilities as healthcare providers, researchers, advocates, and learners. So I'd like to begin by acknowledging the Indigenous peoples of all the lands where we each find ourselves today. While we're meeting on a virtual platform, I do wish to acknowledge the importance of these lands where we make our homes. For thousands of years, these have been the traditional lands of diverse, thriving, and rich Indigenous communities. Today, this meeting place continues to be the home of many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. This also comes with a responsibility for each of us in our institutions to commit to learning about the exploitation, enslavement, colonization, genocide, and ongoing marginalization of Indigenous communities, and how it's contributed to the systems in which we participate and many of us continue to benefit from daily, even today. I understand that this practice of land acknowledgement is only a very small step in the long journey towards true and meaningful reconciliation, which will require dismantling and rebuilding many of these systems together in respectful collaboration. So I'm joining you today from Treaty 13 territory in Peel region, just outside the Toronto area. And I'll pause for each of you also to think about the space where you are today, its history, its legacy, and your relationship with this land. And I welcome you to write into the chat if you do have your own thoughts about acknowledging the land or where you're located today as well. We'll just pause for a moment there. Another dimension of acknowledgement is also our own situation and location as we enter into this discussion. It's really the underpinning of equity and access and is grounded in our own perspectives and positioning. So I hope that this helps us to hold humility and approach our conversation with curiosity as well. So remembering that we take all of ourselves into the work that we do, I'd like to acknowledge that my work is impacted and informed by my experiences as a healthcare provider and consumer, a cis male settler, a person of color, as a parent, as a person with a Canadian post-secondary education in healthcare, someone who is stably housed and employed, someone who is a family member of individuals with chronic health issues, mental health diagnoses, developmental disorders, and individuals who were refugees or internally displaced peoples. And other aspects of myself maybe that I haven't paused to reflect on, but I will pause there for you to take a moment to think about what parts of yourself you're bringing in to the work that you do in working with children and youth and families. And I'd like to also, I've become a big fan of this what, so what, and now what model of thinking about webinars and conversations and learning. And so from an objective standpoint, I'm hoping the what is really, I'm going to go through and try to describe the theory and steps involved with community-based participatory methods, both for research and program design and evaluation in the context of children and youth in Canada. The so what is going to be also considering different approaches engaging with communities as partners that may apply to your setting. And then also the now what in terms of what will you take home. I'm hoping you'll be able to apply a critical lens to current frameworks in research and program design and review opportunities that you may have in your own space for engaging with communities in a meaningful way. And I'm not really into building suspense. So how about I tell you first what I'm going to tell you over the next moments or minutes that we have together. So I'm going to tell you that historical methods of engaging with communities are inequitable and continue to broaden inequities. I'm going to tell you that communities are powerful social entities on their own that have unique strengths, knowledge, values, and perspectives. And I'm going to hopefully convince you that your team would benefit from devising a strategy or revising your strategy for community engagement. So I'm going to pause there again and ask for you, that's what this lightning bolt is. I'm going to ask you to kind of go into the chat and to think about, as we enter into this conversation, what is your perspective on community? What does that look like? Maybe pause for a moment to think about what experiences you've had that shape that view and the work that you carry out. So when you think of community, what does that mean? What words come to mind, and how do you define it? So I see someone saying community is made up of many sub-communities. Yep, I hear the word, or I see the word unity in the chat. Thank you. Maybe also, how do you define community? So someone's saying a place and space of belonging and support. Great. Neighborhoods, people supporting each other. Yeah. Coordination, shared listening and support. Oh, this is lovely. Yeah, and those are really some important notions there, right? About the benefits of communities or some of those characteristics. Someone mentioned neighborhoods, so depicting perhaps a geographic community. And then also we see mention here about having some sort of shared purpose or concerns. Geography has come up, similarities and differences and shared interests as well. So yeah, I think there are, when I think about community, I think about a few different axes to that. So part of it is, what are the communities in which you sit? That might be a good place to start. So some folks might think of community as being related to a geographic space. It could be a diagnostic community. So in my work, I might think of, parents of children who have autism or youth who are autistic or self-identify as autistic. It may be related to other aspects of their identities, such as a cultural linguistic identity, race, gender, gender expression, things like that. So yeah, I was hoping we could pause there for you to think about as we go into the conversation further. What is the community you're thinking about, and might there be space for engagement there? And also important there is when you're thinking about this community is thinking about where does power lie within your community? So what is the role of the clinician, the healthcare researcher, the advocate in relation to the community, and what is that dynamic? So we know that we all sit within multiple communities and there are dynamics of power, privilege, and position within the community. So for example, if you work with children and youth that have chronic illness, how would their intersectionality in their identity impact their participation and ability to self-advocate in healthcare? Let's say if it were someone who were a Black female or a Black trans female or a Black trans female with a physical disability, perhaps a refugee background, whose primary language proficiency was Yoruba. So you can see this is a diagram that's called the power flower, thinking about where power sits within our communities. And so just thinking about as we take all of ourselves into the work that we do in healthcare, so too do our patients bring all of themselves into the healthcare system as patients, as research participants, and community members and patient partners as well. So I urge you to pause and think about who in our healthcare system, or who our healthcare system is built to serve, and whose voices are silent or silenced as we carry out our work as well, and the importance of being able to hear those voices. So traditionally and historically, the institution of healthcare, and as such, its interventions, delivery models, research agendas, and training approaches and values have been led by healthcare professionals, research funders, academic institutions, or healthcare corporations or government bodies. So these groups would then create interventions or deliver programs to, for, about, or on the intended user community or the end user community. So inherently, we understand that these approaches are prescriptive. They're biased, they're skewed by the perspectives of individuals and the groups who hold power, position, and privilege. Again, thinking back to that power flower, there is risk in this imbalance and approach of perpetuating inequities and oppression, even if those are well-intentioned and unknowing sort of impacts. So in recent years, there's been an interest in understanding and incorporating the perspectives of patients and families, but in radical and impactful ways. I'm wondering, can we shift this idea of power over to a situation of power with? Can we create a model of partnership, understanding also that this dynamic may initially, for providers and researchers and clinicians, feel a little bit uncomfortable at first? So how can we, just like the sand in this picture, rebuild the system so it works better for everyone? Or as Faye Johnston, who is an amazing trans rights activist, shares, how can we imagine a world that hurts us a little bit less for people who are in the margins? So I'm going to ask again, just quickly, if you could pause for a moment to think about how would you reimagine our healthcare system? So, I imagine a children's healthcare system where, maybe you could help me finish up the sentence there. And so if you do have any thoughts in the chat, all children matter. Wonderful, thank you. That's so impactful. Maybe a system where no one's left behind. All people feel welcome. Thank you. Maybe I'll take another one or two. Wait times are not so long, right? So we have better access or equal access. Parents from all geographic areas have access to high quality information and services are accessible. Thank you. Thank you for that. And, and as we rebuild our systems or we think about how to do that, it requires us to critically examine our current system and to consider what isn't working for families. But that can be difficult. In healthcare, there can be a sentiment of frustration when families are not able to carry through on our carefully cultivated care plans. And one approach to understanding the root cause of challenges is to ask why at least 5 times. And some of you may have seen this in the past, but I want to introduce you to my patient, Jason. He has autism spectrum disorder, and some of his behaviors that challenge others seem to be escalating. So we would pause to ask, why is Jason's behavior worsening? Because his family has been unable to access ABA or behavioral therapy for his autism symptoms since his diagnosis in 2018. But why haven't they accessed therapy? Because they can't pay out of pocket and they were delayed in getting onto the provincial funding waitlist. But why were they delayed getting onto the waitlist? Because his mother lost the paperwork and she felt too embarrassed to ask for it again. But why was she embarrassed to ask again? Because she's been teased in the past for being absent-minded by her ex-husband, and she's also afraid it will play into negative stereotypes that her racial group is either irresponsible or overly pushy. But why is she afraid of these stereotypes? Because she's afraid that it will change how the doctor and therapist view Jason and that his care will be impacted. But why does she feel that way? But why, right? And so asking why helps us to understand how individuals and communities participate in our healthcare system, what's working, what's not working, and it gets us one step closer to understanding their lived experience, their reality, perspectives, and barriers. And as advocates and healthcare providers, I ask you also to consider the idea that it's not people that fail, but really systems that fail. It would make sense that we try to think about putting ourselves into those people's shoes, those families' shoes. We could guess, conjecture, or extrapolate to try to understand their perspectives, values, or needs, or better yet, we could just ask them. But how do we do that? So there are a few different ways, actually there are many different ways in which one might go about engaging with communities to ask or understand. So you could do things such as community mapping, you could engage over social media, which I'll talk about a little bit, priority setting partnerships I'll touch on as well, engaging through community advisory boards, which has become quite prominent as a model recently as well. Again, important to think about who sits on those boards and who doesn't or isn't able to. Representation on your project teams as well. And then also focus group interviews in a traditional qualitative sort of way to gather some of that information. So creating space for input from families helps us understand their strengths, barriers, relevant content in the context of their health values and goals, and also ideal communication channels, and helps to understand and address mistrust, priorities, and capacity. We know that engagement with families and communities as partners and can, and I would say ought to, happen at all stages of the process in addressing health needs through interventions. So I'm going to talk a little bit about community-based participatory research, and I'll also say program design as well. So CBPR for short has been identified as a methodology with the potential to make substantial contributions to improving the health and well-being of historically disenfranchised populations or marginalized populations. It also builds capacity within these communities as well. And really core here is that CBPR engages community members as active and equal participants, ideally in every phase of the process. It facilitates trust building and enables the rigorous and ethical conduct of research within a community. And really key here in that blue box is it really is intended to honor and recognize the community as a social entity with its own strengths, knowledge, and power as an equal partner in the process of research and program design, and also its revision as well. So you'll see here in this cycle that it's participatory, collaborative, there's mutual exchange of expertise, lived experience, and then content experience. It's meant to be strength-based and sustainable. There's meant to be mutual decision-making and ownership between academic or healthcare partners and community partners. And it's meant to be iterative and long-term and participatory. And that iterative piece is really important. It's meant to be an ongoing relationship. So again, I was using that term cultivated earlier. So, the idea is when an intervention is created, you go back to the community in whatever form that may be to revise that and to take a look at, in that cyclical process, is it serving the needs or that vision that the community originally had? Or are we at a place where it needs to be revised as well? And again, that can be an ongoing process and really ought to be. And although it can take up time upfront and upfront costs to ensure equitable access to participation for community members, we know that CBPR enhances community relevance of the programs within the local context. It increases reliability and validity of tools that may be used to measure outcomes. It improves response rates and retention and accuracy and interpretation of culturally sensitive data. And also really key is it helps to create sustainable community change through improved trust and rapport with the community as well. And I can share some references afterwards if it's helpful for folks who want to read a little bit more about this. So one of our group's projects was entitled the Maple Circle Project, and we attempted to apply CBPR methods to create a parent support program for families of refugee background arriving in Canada or resettling in Canada. And the program focuses on supporting families with children and who have developmental behavioral concerns in their early years. So we understand that families of refugee background may have complex multi-generational mental health and developmental needs that are not accounted for in current programming frameworks. Currently, they would be referred to existing parenting programs that are built to serve mainstream, resource-abundant families, usually employing Eurocentric parenting frameworks. The programs don't account for unique mental health, resettlement, and cultural profiles of families of refugee background. So for this project, we engaged community partners with lived experience in the definition of the question, also funding acquisition, methodological design, consultation, and iterative design and refinement of the intervention as we were designing it as well, pre-pandemic. And a couple of our team members with lived experience shared, and I'm sorry they weren't able to join me today from a scheduling standpoint, but they did share, the first person shared, as a newcomer, a mother, and a researcher from back home, it was great to work on this project. It helped me help others because I went through the same process with my family. I learned a lot about also writing research proposals and grant submissions that will help me in my own career and development, which is pretty awesome. And then another person said, my parents were refugees to Canada working on this project. I thought about them and thought how great it would have been for them to have this kind of support a generation ago, referring to our parenting program. And our amazing community partners for this included, parent partners with lived experience, our caregivers, the Canadian Centre for Victims of Torture, the Regent Park Community Health Centre in Toronto, and the Refugee Hub in Ottawa, the Mennonite Church of Canada branches in multiple provinces, and the Save a Food Bank also in the Toronto area. And our academic partners, the other part of that puzzle piece, was our institution at St. Michael's Hospital, Unity Health Toronto, Women's College Hospital, and the Harvard School of Public Health. And our initial consultation data are presented here briefly in 3 key themes in terms of what parents told us. So for program topics, Parent and community agency stakeholders identified a need to cover topics on typical child development, family resettlement needs, including seeking employment and navigational difficulties for parents, advocating for children in school and the community, and what they described parenting in a Canadian context, including confronting racism, parental self-care, and discussions on corporal punishment and behavior management in the Canadian context as well. Stakeholders also identified barriers to participation in traditional or conventional programs, including language difficulties, competing responsibilities in terms of time, lack of awareness of such programs in their neighborhoods, and the need for anti-racist and anti-oppressive frameworks in the actual curricula that were shared. The discussion around program logistics was also helpful, with families often sharing that they preferred multilingual, multicultural groups actually to share lessons, network, and feel a part of a diverse, rich parenting community, something that was lost for them after they resettled. Families also cited that they enjoyed meeting outside of their home in a central place, and they viewed this as having a positive impact on their own mental health as parents and caregivers. They reminded us that meeting in, common areas that were in an industrial type meeting room or a basement of a community center could be reminiscent of places where they had experienced trauma pre-migration. They also wanted the option for some asynchronous sessions to be available online to allow flexibility in their scheduling as well, if they were caring for children or if they were working, etc. So this program is now being implemented into a virtual delivery platform in light of COVID-19 related restrictions and is being workshopped with community stakeholders for refinement and consensus. So stay tuned for more on how this may impact parental mental health, parenting behaviors, and children's developmental and behavioral outcomes in this community. And when we think about the concept of communities, it can also be important for us to reflect on the communities in which we sit, not only as professionals, but also as humans with our own lived experience. So sometimes, I know particularly within the BIPOC community, there's been a lot of conversation about historically having felt the need to mask that in the name of professionalism. But who we are, with our perspectives, our experience, our culture, our attitudes, adds richness and context to the care that we provide and the systems that we participate in. So as a part of this journey for myself, I'll share, as a clinician who identifies as a Punjabi Indo-Canadian Sikh, a settler, and as a parent, as I mentioned, I work to create, along with a wonderful team, an online parenting support resource called Punjabi Kids Health. Again, this is a different form of community, this time a virtual community. And this came from watching the unearthing of grave disparities in how racialized communities participate in our healthcare system, as we saw during COVID-19, and particularly in my home community of Brampton, Ontario. So at a time when families were feeling isolated and spending even more time parenting than before due to school closures, families were turning to social media to recreate these parenting communities and to share and gain knowledge from one another. In a recent systematic review that we just published, we found barely any social media interventions that focused on the unique needs of racialized or marginalized communities in their parenting or child health literacy journeys. Or in other words, the virtual space of mommy bloggers and even evidence-based parenting resources continues to be exclusive of culturally diverse populations' needs. So we created Punjabi Kids Health, and I invite you to follow us on Instagram and TikTok. We now have about 100,000 followers or online community members, where we share culturally sensitive evidence-based health information that is both for parents and grandparents and practitioners. And we share information from people who look like and speak like the target audience. We attempt to do it in an engaging way with a cultural group that manifests as a really widespread, close-knit diaspora, and a community that does have a deep history of multi-generational trauma, including colonization, independence and partition, and cycles of genocide and a mistrust of Eurocentric institutions. I'll talk a little bit more about that. So, in stepping into the social media space, something I didn't learn about in medical school and residency, I found that social media interventions really are just that, they're social. There is an ongoing conversation with the online community, and we continuously gather data and engage with online community members to get a sense of what their priorities are. And I don't like to call them followers, as we typically think about in terms of social media, because really it's our team that follows their priorities and needs. And so we've covered a range of topics over the last year and a half, including COVID, virtual school, nutrition, oral dental health, We recently had some posts on safety around fireworks for Diwali, which was earlier this week as well, and also aspects of maternal and paternal mental health, and the role of grandparents in multi-generational caregiving practices as well. Again, following the lead of what seems to be doing well with our social media metrics. And our community engagement methods have included online polls, so really easy for people to be able to do on their phone, live question and answer sessions with subject matter experts like dietitians or dentists, healthcare providers, physicians. And also we get a lot of direct messages from community members as well, which we keep track of in terms of, again, what are priorities, what are things we're doing right, what are things we can improve. And lots of community consultations as well. So, community engagement doesn't only have to be with families and individuals, but also agencies who do frontline work with them. So we've engaged with children's aid societies, school boards and educators, and other community agencies who work specifically with the Punjabi diaspora in Canada. And we're now also working on in-depth interviews and focus groups as well. So a few different ways to gather that data. And our preliminary community feedback has really helped inform content, like I was saying, including some surprises for me. And our next steps in developing, our next steps include looking at what are the delivery modalities that people are interested in. And there's been a lot of mention of having specific streams of content, specifically for male caregivers or dads, for grandparents, and then also for professionals who work with children who are part of this community. And as I was saying, we get a lot of feedback. So it's been great to hear from individuals who follow this account and find it helpful because of being able to identify with the providers that are on the account, that there is content that's shared in a multi-generational sort of way, and that it is something that's free and accessible and allows people to connect with each other at a time where it's still quite difficult to be able to connect with a community otherwise. So online communities have been interesting that way. And in reciprocity with the community, again, I was saying CBPR is meant to be reciprocal. So there's supposed to be something for everyone, both the community partners or the community themselves, and also the academic or content partners. So in reciprocity with the community, we're mentoring volunteers and students from the community in research methods and health promotion frameworks. We're intentionally seeking to engage with artists and filmmakers and content developers who are from the Punjabi community for this channel to help provide context to the intervention and to make sure that we are helping support capacity building within the community as well. And we're also assembling a community advisory board, recognizing that even though our team members are members of the Punjabi community, our relative positionality, power, and privilege may not, don't give us all of the insights we need. And having parents from a diverse range of backgrounds or caregivers from diverse backgrounds will help us to guide our content in a more inclusive way. And as I was saying, we also follow our social media analytics as well, which give us data on which content areas are getting the most engagement in terms of views and likes and shares. So again, a new space for me in terms of metrics, but this was something that was very surprising for us. We never thought that our video on tips for children with speech delay would get 250,000 views. Our video on earwax management would get nearly 500,000 views, or our video that's titled, that one was by me, a pediatrician here. As a pediatrician, here are 5 things I'd never do with my own child, would reach more than 2 million views. And so we also see in terms of the analytics that about 2/3 of our community members identify as women, and most are aged 25 to 45. So these are data that are helpful in planning next steps in our content strategy. And we're really pleased to have recently received some funding to scale up the model to replicate and adapt it to a total of 10 cultural linguistic communities in Canada. And this will be under the banner of the Our Kids Health Network. And so in coming months, we will be formally launching social media channels that will be adapted for the Tamil, Arabic, Mandarin, Cantonese, Black, Filipino, Inuit, Hispanic, and Ukrainian communities. And this is in collaboration with the WHO's Digital Health and Innovation Branch, the Canadian Pediatric Society, and engagement from Meta Health, as well as formerly Facebook. And again, keeping true to that original model of representation and having community engagement as a part of it, each chapter will be run by research staff and healthcare providers who reflect the community and share some lived experience, and will be guided by a small community advisory board of caregivers, champions, and lead agencies as well. I invite you to follow along on our journey. I'll share a QR code at the end so you can scan that and follow along on our accounts as they develop as well. Shifting gears a little bit, we also discussed before the question of who sets our programmatic and research agendas. So our departmental group at St. Michael's Pediatrics at Unity Health is right now conducting a priority setting partnership, and PSPs are a really interesting way of approaching how we do what we do, how we choose to do certain things and not others. And so we're engaging with our patient population and caregivers to understand their research priorities in pediatrics, with a focus on underrepresented voices in Toronto's inner city core. And we're keen to compare and contrast these findings with the work that our group is actually conducting, which will be really interesting. As a part of that, we're also formalizing a family partner research and advocacy council to be able to advise on the relevance and scope of our research projects as we move forward as well. So PSPs have been done in other spaces. If you take a look at them online, this term has been used for different spaces. Particularly over the last 2 years, there's been an increase in having a formalized process of gathering data on the priorities of your intended user community, or the folks that are going to be using your services as well, or participating in them. And we've discussed CBPR and what it is and what it can look like. However, when we conducted a systematic review of the nature of the participation of our community, we were looking at with the Maple Circle project, which was families of refugee background. It was really interesting to take a look at what was being done with this model. And so CBPR methods, we found, were primarily being employed and published about with this population in the US and Australia. So those colors, I know it's a bit hard to see. The green and the blue colors are the countries that had the highest number of publications, and then red indicated 1 to 2 articles from those countries, and then gray had no published articles about CBPR methods with families of refugee background. And it's really interesting to see US and Australia creating the bulk of the academic content, when actually most resettled refugees actually live in countries that are adjacent to or close to their country of origin, as opposed to an ocean away. So interesting to think a little bit about that in terms of who's participating there. And then also, when we looked at the various stages of the research process, we found that most projects actually included community partners in defining the research problem and designing the study, and in recruiting or in data collection. However, it was really interesting and rare to find projects that included community partners who were involved in obtaining funding, analyzing data, or in scaling up the intervention or helping to inform policy. And these are really great skills, as one of our team members said in their quotation earlier as well. These are great skills from which community partners could benefit after participating in. And that could be an individual who's a community partner, it could be an agency, but having mentorship and experience with things like funding applications, with helping to put together policy briefs, with scale up or data analysis, are things that would be great to be able to do. So I think while CBPR is being done, I think we could continue to do it better. And again, this is just in the space of refugee health, but in other spaces as well. Just thinking about, as we start doing more participatory work with the communities that we sit in and that we work with, thinking about, again, what is it that's in it for them as well, as we continue to hopefully build capacity as well and exchange our knowledge there. So just some food for thought as you consider how you might engage with community partners. And so I'm going to pause for a moment. Again, here's a lightning bolt suggesting that I'd like you to type into the chat, what are some barriers that you have encountered or that you're envisioning as you think about engaging with a community or the community that you work with as a part of the work that you do in your space? Time commitment, thank you. Yeah, it does take time. Competing priorities. So what are the community needs and what are the funding expectations? And again, causing us to reflect on who sets those expectations or those agendas and priorities as well. Absolutely. Getting the messaging correct. And for the person that wrote that, I would love if you could expand on that in the chat a little bit more about what you mean by that. I think I have a sense, but it would be great if you could add to that a little bit. Lack of internet access for the community of interest. Yeah, absolutely. So access kind of in a very logistical sort of way, having mistrust based on past experiences of being a researcher on and not with. Yeah, so past experiences with how research was done in the past, perhaps with the larger research community, and we know that there are some really painful legacies there. A lack of adequate compensation for participating community members, translating materials appropriately, so for sharing with partners to increase their participation and empowerment in the project. Thank you. And the last one I'll share is using the right words. Yeah, so having the correct tone and addressing the needs of the community as well. Yeah, and I know in a lot of our work, some of our barriers have been aspects of representative hiring, so making sure that our team is authentically representative or reflective of the community that we're working with. So some of those partners may actually come on as employees with the team as well. Engagement can take time, as was mentioned within the chat. So again, can be a bit tricky when the people that make these decisions need some convincing around that. Again, community partners must be compensated just like any of us are paid to be there. They should also be compensated appropriately as well for their time, and thinking about any other barriers to access or participation they may have. There may be mistrust or lack of rapport, and then funding. Obtaining funding can be hard. So if you're going with true CBPR sorts of methods, you want to start with almost a tabula rasa. You want to start off with a clear slate, approaching the community who's the expert in terms of their lived reality and barriers and needs and perspectives and strengths. So hard to put that into a grant application sometimes, where a lot of reviewers are looking for a great deal of detail. And so that requires us sometimes to pivot and shift in terms of where we're seeking funding. That allows us to do that formative work around understanding that agenda as well, but it's out there. And so I'll wrap up in the next slide or two, but just if you are looking for more information, there's some great tips for best practice that our institution, our colleagues at Unity Health have put together. So feel free to screenshot this if you'd like. That's a great link. The resource guide around patient and community engagement and the design and implementation of research studies. And then communityresearchcanada.ca is also a great resource as well. And also, I want to thank my community, who has helped to inform this work, both in research and advocacy. Some of their names are listed there, and they really do lead this project, and we all learn from each other in terms of the work that we do. So again, here's a lightning bolt suggesting I'd like you to jump into the chat. As you think about what I've shared in this last little while, how do you imagine community engagement strategies will fit into the work that you do? And if you're already doing this kind of work, I'd love to hear about it in the chat, or if there are things that you've learned or you think that you might be able to do better based on some of your reflections, either before or coming into this conversation, I'd welcome that as well. So I'm going to open up my chat so I can listen in. But if you do have questions or if you have thoughts there, I'd love that. And I welcome you to type that into the chat. So, as we think about this, what are some things that you think might work? So thank you for folks who are starting to type in. Yeah, co-design at all levels. And, when I started this work, it really struck me that you could actually write a proposal with a community member, that you could actually apply for funding together. that you could start from scratch and really start some of those conversations, which has really been great, and I think mutually beneficial. I also see folks thinking about the design of a community advisory board. Again, I urge you to think about who are those voices that you want represented, who are the voices that we're not hearing from as well. And so I'll mention with our Punjabi Kids Health work that we're doing right now, we recently just received some funding from SSHRC, the Social Sciences and Humanities Research Council, to do kind of more engagement with intersections or kind of further marginalized sub-communities within the Punjabi community as well, including people who may have differences in gender expression, may be impacted by age, minority faith groups as well. So thinking about who are those voices that we really need to reach that are in the margins, that are being pushed to the margins. I appreciate this comment around being purposeful and dedicating time to engage with organizations that support our communities. And then also connecting with ethnocultural organizations to understand the needs of the community and address barriers as well. So important to have those conversations. And I know, I was in a recent conversation, we've been having a bit of a hard time hiring for some of our channels as well. And I know many folks say, from an HR standpoint, it can be hard. We posted for a specific sort of experience or a certain area of lived experience that we wanted to hire from, to have that richness added to our team. But it was a bit hard, and that takes time. It takes, some creativity about working with folks who might know other people who might be interested, with community agencies who do that kind of work, will work with that community that you're trying to really intentionally recruit from as well. And I know some folks, if you're trying to engage with communities and it's not in a research context, I remember in a workshop recently, someone was saying that they sometimes will, just go to a coffee shop in that community, and depending on who you're looking for, but just the Tim Hortons in Canada, tend to have a lot of really wonderful conversations happening there, and getting a sense of who's there, striking up some conversations if you're able to as well. But having those sorts of conversations and ongoing cultivation of those relationships is really key. So thank you to everybody who participated. I will share my last slide here, which has our QR code for if you want to follow along on our journey with the Our Kids Health team. Someone had asked earlier about being able to participate or help with the project. Please do send me an email. My email's on there as well. I'll pause there for your thoughts and your questions. Thank you.
Thank you, Ripu, for this engaging presentation. I'm not sure, it's been a while since we've seen this level of engagement in the chat. And I see our audience has a few questions that have come in. I'm going to take a moment to sort through those, but while I'm doing that, we'd have another set of poll questions for you. And this time you'll have to select an answer to all 5 questions before submitting your response. While you're typing that out, I will start with some of the questions that have come in. One question is, how can we volunteer in Our Kids Health Education and Research work? I heard reach out to you and simply express your interest, but is there any other formal way of participating?
Sure. So I'm putting it in, so you have my email address, and then I'm also putting in the Our Kids Health Unity at unityhealth.to email address as well. So you can reach out either to me or to our manager for the program, who would be happy to talk about opportunities for engagement.
Fabulous. Another question, does your CBPR opportunities invest in educating or training community partners to scale up their skill sets more formally, as opposed to sort of through the work? And if you include community partners as co-authors? Are 2 separate questions.
Great questions, and yes. So, when we have trainings that our other team members are doing, for example, if we have research coordinators or research assistants who are going through a specific training, we invite our community partners to be a part of those as well. Absolutely. Likewise, in the knowledge mobilization and the informal sorts of parts of it as well that we had talked about, absolutely, we do include them in every part that we can, including authorship. And that's something we talk about with that community partner. And so it depends on their level of engagement, but if it's something that is currency for them, if it's something that's helpful in terms of their development, as professional development or whatever it might be, then we have in the past included community partners as co-authors as well.
Wonderful. Another one, while you're all still, it looks like folks are still answering those questions, so I'll keep going. You mentioned hoping to scale this up to other cultural and linguistic communities. What's your process for doing that, and how can others be involved at this very early stage?
Yeah, so it's very exciting. It's happening quickly because of the way the grant deadlines work, but we're hoping to, in the link tree that I've shared through the QR code, you'll see the accounts that have been created. Some of them have some content that's starting to come together. And so right now we're at a point where we're creating the Our Kids Health website, which will be a central hub that providers can go to, that caregivers and families can go to. So it's a bit more searchable than what Instagram and TikTok is right now, where you have to keep scrolling. So if you're looking for specific content, let's say on, constipation in Cantonese, then you'll be able to search that in our website, which we're hoping to launch next month, fingers crossed.
Oh, wonderful.
So watch our Twitter for that in terms of the actual web presence as well. But right now we're actually at a really exciting point where we are pulling together our teams of providers. We have just hired our research coordinators for many of the channels representative of these communities, which has been a really great process. And right now we're actually, you see our Kids Health logo there. We're also engaging with artists from each of these communities then to have their own logo created representative of their cultural experiences and values that will then be customized for each channel. For example, Arabic Kids Health or Cantonese Kids Health will then have artists from those communities creating those logos, and also motifs and colors, so that when folks see our social media content, that it's something that they connect with.
Thanks. Lots to look forward to.
Mm-hmm.
Another question is, how, if you've had to, do you deal with misinformation? Sometimes simply people are misinformed and they're sharing what they believe they know, and sometimes purposeful disinformation. Have you had any opportunity to have to deal with that online?
Oh, yes. Yeah. And so that's been really nice in terms of having some mentorship from the Facebook and Meta Health teams. Actually, one of our co-investigators on the grant, also Dr. Christy Rochke, she is a journalism professor who specializes in misinformation down at Arizona State. And so we're putting together a misinformation longitudinal curriculum as a part of the Our Kids Health channels to help parents identify misinformation, to be able to have those health literacy and media literacy skills, to be able to identify and to think through some of those processes, while also balancing that there may be practices that are not vetted in the same sort of way as we think about in terms of Western medicine,
Right.
that may still have value. And how do you balance some of those complementary traditional alternative sorts of approaches as well? But that's one piece. The other piece with social media is, we joke a lot about trolls online, the people that have not nice things to say or that may be derogatory as well. And so there are some best practices we've developed around that, around how to make sure that it's a safe space for parents and caregivers who want to engage there. And if you are using Facebook for any of your work, Facebook Health does have online certifications that your team members can do, which go through some of these best practices as well. Some of them have also been generated together with the WHO's digital health team. And that's a free certification that team members can do. And that's something that our community members are going to be doing as coordinating these online communities.
Oh, great. I think I have a lot to learn from you myself. Pardon me. What strategies have you used to promote Our Kids Health pages to the communities they're targeted to?
Yeah, so social media, again, it's a new space for us. So some of it has been actually working with the social media companies to promote some of our content to geographic areas or age groups that are part of our intended community. So with PKH, Punjabi Kids Health, and with Tamil Kids Health, which we've started creating more content around as well, we're looking at geographic communities that are predominantly Punjabi or Tamil as a part of their diaspora communities, and trying to push out content there. We're also working with community partners and their social media channels, and we will be having, I think in the months ahead, working with providers who are, healthcare providers that work predominantly in those communities in a primary care standpoint, and creating promotional materials that they can use, whether they're fluent in that language or not. But it would be great for a family doctor or a pediatrician or nurse practitioner to be able to walk out to the waiting room and say, here's a QR code for a video on, speech delay in Arabic. You can scan it on your phone and be able to take that home with you as well. So we're trying to engage with those communities in those ways as well, and trying to get a sense of, from those providers actually, also what are the priority content areas that they see being valuable for their community as well. So a few different ways there.
Wonderful. Kind of crowdsourcing your questions as well.
Mm-hmm.
For this is part of a research project. Do you share the results of what you're finding back with your community partners? And if so, is it through these same channels or other ways?
Yeah, absolutely. And so I would say, with our kids' health, but then also in terms of larger or other community-based projects that are being created, really, we want to ensure that we remember that data, that knowledge really does belong to the community itself. And so you wanted to share it in a way that makes sense. So historically, that has been done through events like a town hall meeting, where the community, so especially if it's a geographic community, is welcomed in, there are refreshments, and then someone kind of shares that content if that works for that community, and kind of sharing what those outcomes were after they participated in that as well. You can also do newsletters, depending on the literacy level of your intended community and their proficiency. And what we've been doing is sharing poll results on our social media platforms. We'll sometimes make videos and say, actually, I'll say with our Kids Health, the biggest hit in terms of our content is at the end of each month, we do 1 week of content, which is all what we call You Asked Us. And so when people write in their questions, we'll have 2 or 3 questions that are chosen. And likewise, we have a We Ask You section every once in a while, where after polling the audience about, for the next back as a video or an infographic, so that it's shared in that same sort of platform and belongs to the community.
Oh, wonderful. And the last question, because our time is coming to a close, what's the biggest lesson you've learned from this work?
I would say, continuing to approach things with curiosity, with humility. I think, whenever we're going through our community engagement activities, I continue to be surprised by the experiences of the people that we're working with, the people that we're trying to create interventions for, whether it's, what is the content that was of interest, what was a barrier that came up, what is a different priority that we had not thought about. For example, with the Maple Circle, we started working with families of refugee background around, what would help you with your parenting journey. And I remember talking to a few parents who said, we're more concerned about getting jobs. So we'd love to learn how to sew, how to put together a resume, how to word process. And so instead of, managing tantrums, which is what we had come in thinking about as well. And so it was great being able to bring those things together, thinking about what are the priorities of folks, because I think they continue to surprise us with our team as we engage with community partners. So again, so valuable in thinking about how do we, carry this work forward.
Absolutely. Those social determinants of health are huge in most populations. Well, thank you so much for your time today, Dr. Minhas. It's it's the end of our time together, but I want to thank you for such an engaging discussion and thank our audience members for joining in. We know how busy you all are right now, and we hope you depart with some practical knowledge to bring back to your organization. Watch out for our next episode of Spark Conversations podcast series, Community Hospitals, Key to an Integrated Healthcare System for Children and Youth, which we'll launch on October 31st. And this episode will involve our new Season 3 podcast host, Dr. Catherine Smart, in conversation with our special guest, Alison Quigley, who is Senior Vice President of Patient Care Services and a Master Plan at Trillium Health Partners. And next month is the Spark theme month is leadership. And we're excited to bring you more Spark content, including our annual conference. Registration is now open for that conference. It's hybrid this year. We're inviting people in person or virtually. It's a celebration of our leaders in children's health, and with the theme of energy, optimism, and leadership, a bright future for child health in Canada. It'll take place during Spark Child Health Leadership Month and provide several touch points for broad child and youth health community to come together and content focused on a variety of audiences. In association with that conference, we're also pleased to offer 2 CMA PLI courses, workshops that are accredited physician leadership conferences, but they're open to all professions. The courses are focused on foundations of wellness, organizational interventions to protect against burnout and create conditions for resiliency, and leading change, how to motivate, implement, and sustain change in complex systems. Certainly timely content given the state of the world today. Both are 3 hours long, hosted virtually. You can check them out on the conference website, which is available on our new website. You may have noticed a change in the face of our organization online. We have a brand new website that we hope you'll check out, and look back for future Spark content as well as information on the conference. So thanks again for joining us today. Thank you for Dr. Minhas for this presentation, and hopefully we'll see many of you back here in November. Bye, everyone.